Afternoon all. Today we are going to discuss regarding the dysphagia. Today we are going to discuss regarding the what is the physiology of deglutition, what is the definition of dysphagia, what are the causes of dysphagia, what are the clinical manifestations. If patient comes with dysphagia, how to approach the patient. If suppose what are the management approaches for the patient with dysphagia. Today we are going to discuss all these things. What is the definition of the dysphagia? Dysphagia is the difficulty with swallowing. It refers to the problem with the transit of the food or liquid from the mouth to hypopharynx or esophagus. What is aphasia? Aphasia is complete obstruction of the esophagus. It denotes the complete obstruction of the esophagus. What is aphasia means? It is unable to swallow. It encountered in acute setting of food bolus infection, foreign body infection. What is odonophasia? Odonophasia is the painful swallowing. What is transfer dysphagia? Due to this transfer dysphagia, nasal regurgitation, pulmonary aspiration will occur. It is a characteristic of oropharyngeal dysphagia. What is phagophobia? Phagophobia is the fear of swallowing, and refusal to swallow may be the psychogenic. Before going to discuss regarding the physiology of deglutition, we have to know the nerve supply. What is swallowing? Swallowing is a reflex process. So it means sensory nerves are there, motor nerves are there. So if suppose when football is entered into the pharynx, the receptors present on the base of the tongue, soft palate, facial arches, tonsils, and posterior pharyngeal wall. These receptors from this receptor, sensory information carries to the swallowing center. From swallowing center, there are connections to the cerebral cortex and nausea and vomiting center. How the sensory input carries through the 7, 9, and 10 cranial nerves. Did you understand? First, sensory information carried by the 7, 9, and 10 cranial nerves to the swallowing center. From swallowing center, there is connections to the cerebral cortex and nausea and vomiting center. These all are involved in the coordination of the swallowing process. Once the sensory information reaches to the swallowing center, from swallowing center, again that information conveys back to the muscles which are helping the swallowing process through the nerves 5, 7, 9, 10, and 12. Okay, this is motor information. Physiology of deglutition. Deglutition is a complex process. So it involves the series of voluntary and involuntary neuromuscular contractions. It is typically divided into 3 distinct phases: oral, pharyngeal, and esophageal. The oral phase is the voluntary stage. The oral phase includes mastication and formation of the food bolus. Once food bolus is formed, it enters into the hypopharynx. This pharyngeal stages will start. The pharyngeal stage and esophageal is an involuntary and reflex process. Oropharyngeal phase includes so many movements will occur in our oral cavity and the pharynx. That are first elevation of the tongue, posterior movement of the tongue, elevation of the soft palate, and elevation of the hyoid, elevation of the larynx, and closure of the epiglottis. Swallowing process occurs during expiration. It means vocal cords also will close during swallowing. Once elevation of the tongue and posterior movement of the tongue occurs, that food bolus reaches to the pharynx. Then that elevation of the soft palate will occur. Elevation of the hyoid and elevation of the larynx. Larynx elevated and pulled forwards. And closure of the epiglottis. These are the changes will occur during the pharyngeal phase. Pharyngeal phase is a voluntary process, reflex process. Receptors that already I discussed before slide, that the sensory information carried through the 7-9 turn nerves to the swallowing center. From swallowing center, again information come to the muscles which are involved in the swallowing through the 7, 5, 9, 10, 12 nerves, cranial nerves. These are the changes occur during the pharyngeal phase. Once footballers reaches to the hypopharynx, that upper esophageal sphincter relaxes and opens. Uh, then starts the esophageal phase. Esophageal phase involves the three: primary peristaltic wave and secondary peristaltic and tertiary peristaltic waves. That upper one third of esophagus consists of striated muscles. Lower two third of esophagus consists of the smooth muscles. So that pharyngeal phase also involves the first primary peristaltic wave. It is controlled by the enteric nervous system. This secondary and tertiary peristaltic waves controlled by the mesenteric plexus and myenteric plexus. These are the sympathetic and parasympathetic nerves. Okay. Esophageal phase includes primary peristaltic waves and secondary and tertiary peristaltic waves. What are the causes of dysphagia? What are the causes of dysphagia? Causes of dysphagia are structural and propulsive. What is structural dysphagia? Any abnormality in the oral cavity, tongue, pharynx. And if suppose lumen of passage of footballers through the pharynx esophagus, if suppose that lumen is narrowed, it causes the obstruction. It is that structural dysphagia is due to this narrowing of the lumen. What is propulsive dysphagia? Propulsive dysphagia is due to abnormality in the peristaltic movements and abnormality in the sphincter relaxation. These are the propulsive dysphagia. Cause of dysphagia again divided into oropharyngeal dysphagia and esophageal dysphagia. The oropharyngeal dysphagia again divided into structural and propulsive. What is the structural dysphagia? Structural dysphagia is due to a luminal obstruction. Propulsive is due to abnormalities in the peristalsis or abnormality in the relaxation of the sphincter. What are the structural causes of oropharyngeal dysphagia? That Juncker's diverticulum, neoplasm of the oral cavity, tongue, the pharynx, cervical webs. That cervical web causes the constriction of the upper esophagus, cricopharyngeal bar, osteophytes, congenital abnormalities, and post head and neck surgery, chemotherapy, mucositis, radiation. Radiation causes the scarring and fibrosis of that area. It leads to the luminal narrowing. Corrosive injury, infection. These are causes the structural oropharyngeal dysphagia. Propulsive again divided into neurogenic and myogenic. When that propulsive dysphagia, when it will occur, any problem within the CNS problems, and neuromuscular junction problems and muscle problems. Neurogenic causes are the CVA, Parkinson's, amyotrophic lateral sclerosis, brainstem tumor, GBS, Huntington's chorea, post-polio syndrome, multiple sclerosis, cerebral palsy. These are causes the neurogenic oropharyngeal dysphagia. Myasthenia gravis, polymyositis, mixed connective tissue disorders, oculopharyngeal muscular dystrophy, paraneoplastic syndromes, myotonic dystrophy. Sarcoidosis are the myogenic propulsive oropharyngeal dysphagia. Esophageal dysphagia again divided into the propulsive and the structural. Propulsive causes are the gastroesophageal reflux disease with the weak peristalsis, eclasia, diffuse esophageal spasm, scleroderma. What are structural esophageal dysphagia causes are the intermittent dysphagia is Scratch-ring. Scratch-ring is the upper esophageal web. It causes the intermittently difficulty in swallowing. Then progressive dysphagia causes the carcinoma of the esophagus. Variable dysphagia includes cause of variable dysphagia includes peptic stricture, eosinophilic esophagitis, hiatal hernia, extensive compression by the aortic arch and all, surgical stenosis, radiation esophagitis, ringed esophagus, congenital esophageal stenosis. What are the causes of the structural causes of the esophageal dysphagia with odonophagia? Infectious, caustic injury, chemotherapy, mucositis, sclerotherapy, Crohn's, Behçet's, fullness lymphoid like implants. These tables are taken from the Harrison. If you go and check, you will learn more things from the textbook. How a patient with how if suppose patient is having any problem within the oral cavity, hypopharynx and esophagus, then he will present with pain and difficulty in swallowing, sensation of the food being stuck into the throat or chest, coughing, gagging while swallowing, nasal regurgitation, dysarthria, nasal speech because of the associated muscle weakness, frequent burning sensation in chest, having food or stomach acid back up into the throat, unexpectedly losing weight. If suppose condition of the patient came and he is giving history to us. The patient is telling weight loss, elderly patient, and epigastric burning sensation and all, weight loss in elderly patient, we will suspect first carcinoma. If suppose weight loss with regurgitation, we will think of achalasia cardia. Difficulty in initiating swallow, it means oropharyngeal dysphagia. It could be a pharyngeal carcinoma, any esophageal webs, upper esophageal webs. Like suppose food sticks after swallowing the chest, it means esophageal dysphagia. Progressive dysphagia initially to the liquids, initially to the solids, then liquids. It means progressive dysphagia. Initially to the solids, then liquids, then complete dysphagia. Then we'll think of neuromuscular dysphagia, carcinoma of the stomach, carcinoma of the esophagus. Next, intermittent dysphagia. Intermittent dysphagia always consists of rings and webs, upper esophageal webs, lower esophageal webs. And it also cause the propulsive disorders, that diffuse esophageal spasm. Dysphagia related to the solid foods only, that is obstructive dysphagia. Both solids and liquids, that is neuromuscular dysphagia. Regurgitation of the old food and halitosis suggestive of juncus diverticulum. Dysphagia relieved with repeated swallow, achalasia cardia. There are 6 grades of dysphagia. Grade 1 complains of the dysphagia, but still he is eating normally. Grade 2 is requires a liquid with meals. Grade 3 is able to take semi-solid but unable to take any solids. Grade 4 is able to swallow liquids only. Grade 5 is unable to swallow liquid but able to swallow saliva. Grade 6 is unable to swallow saliva also. How we have to evaluate the patient with dysphagia? First, we have to take the history of the patient. What is his age, sex, smoker, and any food habits, whether economic status. All those things we have to evaluate. We have to take proper clinical history. We have to ask all those things: smoking history, alcohol history, personal history, past history, any drug history, allergic history. All those things we have to ask. Then we have to examine the patient properly. Then we have to do blood investigations. Then we have to do X-ray, barium, CCT, thorax, neck, CCT, thorax or neck, any masses and all. We have to do upper GI endoscopy, laryngoscopy, manometry, 24-hour pH monitoring, endoscopic ultrasound, histopathology. This image suggests of that foreign body infection. These are the X-ray chest and neck. Foreign body infection in the upper, this is pin is located in the pharynx. These dentures are in the upper esophagus. These diagrams show barium swallow. Barium swallow, it's showing the epiphrenic diverticulum. This image showing the juncus diverticulum. This nutcracker esophagus is also called the diffuse esophagus due to diffuse esophageal spasms. This metaesophageal diverticulum. These are the barium swallow imagings. Eclasia cardia, it could be a bird beak sign, and could be a sigmoid esophagus. These imagings suggest of strictures causing the injury due to strictures due to caustic injury. These are the striding hernia, and this is due to third image due to carcinoma of the esophagus. There is the irregular filling defects. Cine radiography, it is the dynamic assessment of the dysphagia. It is a radiographic visualization of the food bolus movement from the oral cavity to the hypopharynx. Endoscopy we can use two ways: diagnostically and therapeutically. For therapeutic use, it is useful for the foreign body removal, for putting stents and for putting for doing dilatations and all. Diagnostic endoscopy. For diagnostic, we should visualize the lesion of the esophagus, any carcinoma lesions. If you want to take biopsy, you can take biopsy from that lesion. These are the images showing the endoscopy images. First image is Barrett's esophagus. Barrett's, that is GE junction. Barrett's esophagus, that is second image is Scotty ring. Then third image is esophagitis. Fourth one is esophageal diverticulum. This is foreign body impaction, that is bone. First image is foreign body impaction, bone. This is pharoesophageal hernia. These are the corrosive strictures. These are the carcinoma esophagus. Manometry. Manometry is if suppose what is meant by eclasia cardia. Eclasia cardia is that lower esophageal sphincter unable to relax. It means they're unable to relax. So dilatation of the esophagus will occur. And that lower esophageal sphincter pressures are very high, so it unable to relax. So that food and particles will dump and that esophagus gradually dilate. So we have to know the pressure of that lower esophageal sphincter. So manometry is useful for the measuring the pressures of the lower esophageal sphincter. So indications of the manometry are the eclasia cardia, diffuse esophageal spasm, nutcracker esophagus, and hypertensive esophageal sphincters. What are the types of manometry? Stationary manometry and high resolution manometry. These are the images of showing that pressures. First is normal peristalsis. Second one is absent peristalsis, that is eclasia cardia. The third one is nutcracker esophagus. Fourth one is diffuse esophageal spasms. We have to monitor the pH of the esophagus. That is by the 24-hour ambulatory pH monitor. It is useful in reflex esophagitis. That how we will measure the pH by putting electrode to the esophageal mucosa. Then we will monitor the pH. This endoscopic ultrasound is useful for the carcinoma esophagus for staging. Staging this endoscopic ultrasound is useful. Then it is also useful for the biopsy taking also. Histology. After taking biopsy, we have to know whether it is a carcinoma, it is a benign lesion for this region. This biopsy of lesion will send to the pathology lab and will diagnose whether it is Barrett's esophagus, squamous cell carcinoma, and adenocarcinoma. According to this histology, we will treat the patient according to that. Treatment first we have to ask the patient lifestyle modification and drug therapy. Therapeutic endoscopy will be useful for the foreign body removal and dilatation. If any stricture is there, we'll do dilatation and all those things. Stunting, chemoradiation, surgery. Lifestyle modification, this includes the avoidance of the precipitating foods, that fatty foods, alcohol, caffeine. Oral hygiene should be maintained. Avoidance of the recumbency postprandially. Elevation of the head of the bed. Smoking cessation. Weight reduction. Drug therapy for the esophageal dysphagia, that for that reflux esophagitis, H2 blockers, antacids, proton pump inhibitors, metoclopramide and domperidone. Motility disorders. For motility disorders, nitrates are useful. Calcium channel blockers are useful. Sildenafil and Botox injection. Dilation indications are strictures, the upper esophageal web, achalasia cardia, and anastomotic stenosis. Stunts indication is carcinoma esophagus. It gives the palliative support only, not full cure. It only gives the palliative support. If suppose patient is having carcinoma esophagus, he is unable to swallow. So then we have to put the stent, and we'll increase the lifespan of the patient. Chemoradiation indication is also carcinoma esophagus. If suppose early stages, grade 1 to 3 dysphagia, chemoradiation will give neoadjuvantly. If suppose severe dysphagia, will give along with chemotherapy. Surgery, if suppose any diverticulum, example Junker's diverticulum is there, we have to do diverticulectomy and plus myotomy. There cricopharyngeal muscle myotomy will be there. Should we have to do myotomy for the motility disorders. So what are the motility disorders? Achalasia cardia, diffuse esophageal spasm. Myotomy also useful for the neuronal dysphagia. Fundoplication for the reflux esophagitis. Hernia repair for the hiatus hernia. Esophageal resection and reconstruction for the malignancy of the esophagus, long-standing achalasia and caustic injuries. Thank you. Front means 40 slides.